Welcome to UofL Today with Mark Hebert on 790 WKRD. That is Cards Radio, 790 WKRD. For those of you who haven't joined us before, this is the show that's about all things University of Louisville, where we interview folks, students, faculty, staff, others, about what's going on at UofL. On the show today, you've heard an awful lot lately about vaping. Some states are banning e-cigarettes because of lung injuries related to them. Two University of Louisville professors have done a lot of research on why teens are vaping, and you'll be hearing from them. And UofL has a new model for teaching doctors at the UofL School of Medicine, and we'll hear about that. But first, you may be one of the millions of people taking a statin to lower your cholesterol. Well, maybe you don't need to. New guidelines for cholesterol came out late last year, and Stanley Levinson is an adjunct professor of medicine at UofL, and he's a former professor of pathology, a professor emeritus in pathology at UofL, and he's here to talk about the new standards and the new guidelines, I guess, for cholesterol, right?
Yes.
Stan? All right. So, first of all, I guess, what is cholesterol? How do you describe it to people? What do you tell them?
Well,
I know you're not a medical doctor, but
describe it to people in terms of what it is. But it's a lipid, and lipids are a heterogeneous group of substances that are not soluble in water.
Okay.
And this is one of those substances, and it's hard to exactly describe the molecule.
Well, you don't need to get into all that, but
it is the basic molecule that's synthesized into cortisol, which is the adrenal hormone, and a number of other adrenal hormones. And it's also synthesized into bile acids and a variety of other substances, all of which have a basic cholesterol-like structure.
Okay. All right. So we know the medical, or the chemical makeup of cholesterol, what it is. So you looked at the guidelines for cholesterol and what the changes have been over the years for doctors,
Yes.
and what they tell patients who walk in and say, hey, I got high cholesterol. What should I do? What's high? What's not high? What's low? What's not low? So what about the guidelines? Who are they set by? First of all, who sets the guidelines? And then what'd you find?
Well, the guidelines are actually set by a national committee that's right now, and it's changed as to exactly who it was. At one time, it was National Cholesterol Education Program, which was actually a part of the CDC.
Okay.
Now the guidelines have been taken over by the American Heart Association largely.
Okay.
And generally those guidelines are affirmed by the Diabetic Association, the Kidney Association, and other.
So all these medical societies, et cetera,
Yes.
they go along with the guidelines that are set up. All right. So what'd you find? What are the differences in what the cholesterol guidelines were that your doctor would tell you about in 2013?
There were guidelines that came out in 2013, and these changed the prior guidelines, whereby they no longer focused on targets. Like, for example, people at very high risk should be less than 100 milligrams per whatever of
the bad
LDL cholesterol,
which is the bad cholesterol,
being among the bad cholesterols.
All right.
Okay, but actually, the bad cholesterols include what's called very low density lipoprotein cholesterol and intermediate density lipoprotein cholesterol, as well as LDL cholesterol. And these cholesterols actually go one to another, and we like to talk about them as being the beta cholesterols, and all of those would be considered bad cholesterols, although the focus has much more been on LDL cholesterol.
All right. So in 2013, the guidelines changed. Like you always heard when I went to get my cholesterol checked, that if your total is over 200, you should be on statins. So they got away from that in 2013.
Right. They got away from that in 2013, but then they got back to it in 2016, and they extended it in 2017, and again came out some more in 2018, and all of these, again, introduced targets. Very high-risk people should be less than 100 milligrams. Very, very high-risk people less than 70 milligrams. And for people at moderate risk, I suppose 130 milligrams is still acceptable, although now they actually have a program into which you put HDL cholesterol, the so-called good cholesterol, and you put your LDL cholesterol, whether you're a smoker or not, whether you're diabetic, and a number of other parameters in, and this will tell you what your risk is, and if you have a greater than 7.5% risk, you should be on a statin, or at least some cholesterol-lowering drug.
All right. So again, we're talking with Stan Levinson, who's an adjunct professor of medicine at UofL and a professor emeritus of pathology at the University of Louisville School of Medicine. So what should folks take from this? When they go to their doctor and their doctor says, the guidelines for cholesterol, yours is too high.
Okay.
What should I take from that?
Well, it's a little bit more complicated than that because it's true that some people have a very high cholesterol, and those are usually familial. That is, it's genetically introduced. But actually, the greatest number of people have a different kind of dyslipidemia. And this kind of dyslipidemia is one in which the LDL cholesterol actually tends to be fairly low. But what they have is elevated triglycerides and a reduced HDL good cholesterol.
That's me. I got high triglycerides and not enough good cholesterol.
All right. Well, and it's a little surprising, although I have that as well. But in fact, the great majority that have this so-called atherogenic phenotype are people that are either overweight or obese.
That's not me.
That's not you for sure. And so, but you probably should be, at your age, you should be taking a statin to lower your cholesterol even more, your LDL cholesterol even more than it is.
Okay.
So
that's what people should take from this, though, that there's more to it than just having high rates of bad
especially
cholesterol.
Today, where so many people are becoming overweight and obese. This particular phenotype, which increases the risk of coronary disease, is becoming more and more prevalent among this group of people. And in fact, their LDL cholesterols may not be very elevated, but indeed they will come out in the program as being high risk. The reason for that is because they're going to have a somewhat low HDL cholesterol, a somewhat high triglyceride, and they may also have high blood pressure because that tends to go with obesity as well, and with overweightness. And of course, if they're smokers, they're at very, very high risk. And they may even have, many of them, diabetes.
Right.
And so all of these people, even if they don't have a really high cholesterol, they should be on a statin. But the most, modification of behavior, that is to lose weight.
Right.
That is the most important goal. And the guidelines stress that the first thing one should try and do is lose weight.
Right.
And the reason for that is, see, we used to think that fat tissue was didn't do very much, just sort of sat around. But now it's known that it's a very active tissue, and it becomes more and more active as more and more fat is deposited.
Well, and it can block your arteries and do other things,
Yes.
right? And that's the problem with having
and it
cholesterol.
actually, fat tissue secretes 3 hormones, and as it becomes more and more, gathers more fat, it becomes more like immune tissue. Mm-hmm. And it secretes various kinds of molecules, and these sort of put a person into what might be called a chronic immune response.
Okay. Well, we need to kind of wrap this up. So the bottom line is that if you're going to your doctor, ask your doctor, I guess, isn't it?
Yes.
Shouldn't you ask your doctor?
Your doctor should point out
Okay.
that you may need
Do the cholesterol test,
yeah.
but he also should, he or she, the doctor.
But if the doctor doesn't say it, it's always worth asking. Do you think I should be on a cholesterol-lowering drug?
And do I mean,
and
where am I on the
especially if
guidelines?
you're overweight or obese,
Okay.
very likely you should be.
Okay. Stanley Levinson, good to see you again. Joy Hart and Kandi Walker have been on this radio program a number of times. They are both communication professors at UofL, have done a lot of surveying and studying attitudes about vaping, e-cigarettes, and tobacco products in general. Well, welcome back, ladies. Good to see you.
Good to see you.
I keep hearing this stuff in the news about vaping or something. Is this a new phenomena? I've just heard a little bit about that there's some problems with it.
I think it's because of your show,
Oh,
us
is that what
talking
it is?
about it,
Okay.
that all of a sudden it hit the media widespread.
Go figure. Go figure. Well, as you know, in all seriousness, there has been a lot going on since you've been on this program a couple months ago about vaping, e-cigarettes. There have been Surgeon General warnings. A number of states are banning the flavors in e-cigarettes and those kinds of things. So let's talk a little bit about your work, which involves basically a lot of surveying and studying on this, right? The role of flavors. People have been talking about that the flavors are the way that youth are getting sucked into smoking e-cigarettes, or vaping, I guess is the better term. So you did a study. What'd you find?
Well, it's funny because we've been doing this research for a number of years now, and just in the last month or so, that's when the media really took notice. There are problems with how people are using e-cigarettes, and there are reasons why people are using e-cigarettes, and especially if we start looking at young adults and why they are starting to use the Juul product, is starting to use e-cigarettes, that if we look at flavors, it all comes back. We start seeing a trend that flavors really influences people's behavior. Mm-hmm. They like the different flavors. It is one of the reasons we did a study. We looked at over 1,400 participants, and one of the main findings was flavors was the reason they initiated their use of e-cigarettes.
So flavors draw people in, and then flavors keep them going. So there are really two parts, the getting started and then the continued use. And there are so many different flavors on the market that people can find anything that they're interested in.
I saw one that was
create their
blackberry.
own. Yes.
Blackberry e-cigarettes and different flavors like that. So with these 1,400 that you surveyed, were these all youth? Were they all adults, or was it a mixed bag?
We did it was a mixed bag, but for a couple of the studies that have been getting some attention lately, we were really drawing into a more narrow focus of just the young adults.
Mm-hmm. Go ahead.
And
I'm sorry,
Joey. We'll come back one day and talk about our youth work. But we looked at a range of adults, but honed in, as Kandi was saying, on the 18 to 24-year-olds in terms of their influences, and compared them to some folks in other age groups.
Okay, so go ahead. I'm sorry.
No, we just found that we noticed that flavors was the reason why they wanted to try e-cigarettes, and once they tried it, we also noted that there was a trend that people that were satisfied with their e-cig use were people that used flavors, and people that were more addicted also used flavors.
So is this like the old-fashioned menthol cigarettes? Is that why tobacco companies put menthol in cigarettes to keep people smoking, because they got better satisfaction out of it?
Well, mint and menthol came up as one of the flavors that really influenced people's behavior and
so they're
choices.
menthol e-cigarettes? Well,
Absolutely.
I don't know. I don't vape.
And it was one that was categorized separately so that we could see, does that flavor in particular have an influence on people? And it does.
And you mentioned blackberry. There's an array of fruit flavors too, and those are particularly attractive to folks in that younger age group as well. Also, you mentioned mint and menthol cigarettes, and in some of the bans for flavorings that are being discussed or called for, they wouldn't ban tobacco-flavored e-cigarettes, but they might ban all other flavors. Menthol is getting some discussion because, of course, that exists in cigarette flavorings.
Right. And right now, I think I read something that there are now more teenagers vaping than there are smoking old-fashioned cigarettes.
Oh,
is that
absolutely.
correct? Is it by a lot? What are the percentage?
And use between 2017 and 2019 more than doubled. There's a new article in the New England Journal of Medicine that looks at over 40,000 youth in 12th grade, 10th grade, and 8th grade, and the rise just since 2017 is astronomical.
So these kids are getting hooked, and it
They
is
are.
addictive.
Yes.
It is addictive. All right. Again, we're talking with Joy Hart and Kandi Walker, who are both communications professors at the University of Louisville and have done a lot of studying and research on e-cigarettes, vaping, and also on old-fashioned tobacco products. products as well, the attitudes and why people are smoking, basically. Let's talk about another study that you looked at, the age difference in who is using e-cigs. What'd you find?
We'll start this one.
Sure. So, e-cigs are used across a range of ages, and again, we didn't in that study look at under 18-year-olds, but we have some other work that does. But in this study, we compared younger adults to folks in other categories and found that they were more drawn to certain aspects of e-cigarettes, and they were less interested in some other things like quitting, for example, or they weren't using them as often to avoid cigarettes or to quit smoking, but they were using them just because they liked the products and they liked the experience.
We acknowledge that some people do use e-cigarettes to help with cessation of regular cigarettes. But what we're finding in our research is that the young adults especially are using e-cigarettes because of the flavors, and then they become sustained users. And that's a little bit of a difference between our older and our younger cohorts.
Okay, so
And
go ahead,
I think that's
Joy.
especially a problem with people who are under 18. Again, we're not so much focusing on them today, but folks who start using nicotine prior to their 18th birthday are much more likely to become lifetime smokers. So you can guess what companies might want to advertise to them. They're, much more opportunity to sell products over the long term. So if you can prohibit use or get used to stop before that sort of threshold, there are also dangers for young adults even who are past 18 in terms of nicotine's effects on the brain, for example. But even older smokers who are using the products to quit, and some people have been successful for that, not all. Some become dual users or multi-users of products. But there are other documented successful ways of quitting using traditional tobacco if that's the route you want to go. That would save you from some of the problems with e-cigarettes that you're reading about in the news these days.
Right. We're talking with Joy Hart and Kandi Walker from the University of Louisville, who've done some research on e-cigarettes. So are some adults, or what percentage of adults, I guess is the better question, are saying that the reason they're smoking e-cigarettes and vaping is because they're trying to quit, they're trying to wean themselves off old-fashioned cigarettes?
It was one of the highest 3 reasons in that study that we did in terms of why people are using them.
Okay, but obviously
So
that's not
perceived health, they are perceived as less harmful was one of the top 3. To quit using traditional tobacco was another in the top 3, and flavors was another.
Okay, and that's for adults now.
Yes.
And the reasons for kids, as Kandi pointed out, is a little bit different.
That's right. Flavors are going to be at our top.
Is peer pressure in there somewhere?
Absolutely. We start looking at, well, who's offering, where are they, what are they doing? And we see that your friends are still having, just like we did in traditional cigarettes, your friends smoking, having their smoke break. Now we have it as friends are vaping, so now they're wanting to have a vape buddy.
Okay. So parents are getting more and more education as we see stuff in the news about these e-cigarettes. Again, going back to the Surgeon General issued an advisory. Some states are trying to ban them, or at least the flavors in them. We've got some people dying that have been vaping, and some states trying to regulate that. So what should parents know from what you've seen and the kids you've talked to as part of your surveys? What should parents know, and what should they be telling their kids that might work to keep them off these?
I think one of the things they need to have that communication, they need to have the talk with their child, because these products can be hidden. It is not like your traditional cigarette that has the smoke and that has the smell that will linger on you. It's not like the earlier models of e-cigarettes where they're a little clunkier and they did have smoke clouds or vape clouds. What we're looking at now are products like Juul or pod-based units that can be hidden in almost anywhere. They can be used in class. They can be used in a car, probably in the same car with their parents, and the parents may not know. So they have to be vigilant about having the conversation that just because you don't see it or smell it doesn't mean that it's not being used.
Joy?
There's some evidence with traditional tobacco that just having your parents not want you to do it, or being open and having conversations, is a factor in youth decision making. And I think, as Kandi was saying, recognize, have the communication, but also watch for signs, because and as certain things become known, then companies produce other things. So we were just seeing examples like a watch that looks like an Apple Watch that you can tap and it gives you the time, but you take it off and it's a vaping device, or a hoodie that has strings and at the end of one of the strings is a vaping device. So there are lots of possibilities for how you might not notice these things.
And the two things, I guess, for parents are, A, nicotine is addictive, and there was just a study out that showed that some of these e-cigarettes can cause cancer in mice. Not with humans yet,
And
but we've got a brand new study.
Not just cancer, but heart problems, many types of effects.
All right. It's always great to talk to you, too. I'm sure we'll be having you back to talk some more about this, because this is just a blossoming topic, e-cigarettes, and there's a lot of unknowns about it. So we'll keep harping on it here at the University of Louisville. The University of Louisville is using some new and different tools to teach and mentor current and future doctors and faculty members. Dr. Michelle Stevenson is the head of the Division of Pediatric Emergency Medicine at UofL, and she's here to talk about those efforts. Michelle, it's good to see you.
Thank you so much. I really appreciate the opportunity to be with you today.
Yeah, glad you're talking on the show here. All right, well, let's talk a little bit about you are, I guess, teaching current faculty, former faculty, new faculty, students. Who are you working with at the School of Medicine?
Yeah, so our faculty in pediatric emergency medicine has a training program and in fellowship to train new doctors in our subspecialty. But we also train general pediatricians, and a lot of the work that we're going to talk about today really focuses on training those general pediatricians to do research, and that has been the overarching goal of the team of the mentorship model that we're going to talk about today.
All right, well, let's talk about the mentorship model. What is the mentorship model? It's got a special name. Aspect? Is that right? Okay.
So it's accelerating scholarship through personal engagement with a collaborative team.
Everything has to have an acronym, right?
Absolutely, right? But this acronym, I think, describes a lot of what we have done through the years in this group of 4 women that's gotten together to work on resident scholarly activity.
Okay, so what does it do? What's Aspect? What are you doing on a daily basis with these pediatricians?
So we have 4 women in academic medicine in pediatrics that are across the country that got together starting in 2012 around how best to support pediatric residents to learn to do research and scholarly activity. And we found that we had this common interest about, supporting these growing pediatricians, and got together on a regular basis through conference calls and began to do research on the topic. And we enjoyed working together so much, and we found that our group was able to collaborate effectively, that we wanted to share our experiences with how this model had supported us in our personal and professional careers.
We're talking with Dr. Michelle Stevenson, who's the head of the Division of Pediatric Emergency Medicine at UofL. We're talking about a training program, basically, for pediatricians, and I think, as I understand it, you're aimed at women mostly, right? That's who you're.
Well, it just so
or not.
Well, yeah, no. I think that
Okay.
That we've learned a lot of things about how to support women faculty. It just so happens that our group of collaborators are all women in academic medicine. Although I think we all feel that some of the things we've learned are applicable to any other group of academic physicians or academic faculty in other disciplines as well. There are some unique aspects of women faculty in academic medicine that are challenges in terms of parity in opportunities for promotion and advancement. And we believe that the Aspect model is one way to help address that and help promote the success of women faculty in academic medicine.
So what are the practical things that this Aspect, I'm going to call it training or mentoring program, whatever you want to call it. What are the things on the ground that you're doing to help other women and other pediatricians in general become more involved in research? And what are you doing?
Yeah, so one of the ways that we're wanting to help women faculty is just by sharing our experience, and that's essentially what our publication is doing, and that is that there are opportunities to connect with other faculty at national meetings, which is how our group got started, and so encouraging faculty to make those connections and then schedule some structure around fostering those connections. So our group on our calendars for the entire academic year has twice a month conference calls that are already scheduled in. And we found this to be very helpful in promoting the work that we've been doing, and just offering an opportunity to connect on a regular basis and move projects ahead. We've also been really flexible. So if we've had one member of the group that has had something come up in her personal or professional life, we've been able to accommodate that and redistribute tasks to the other members of the group. And we've had a lot of clear communication about who's leading which aspect of the project, and a lot of open discussions about where we want our program to go next.
Sort of a shared experience kind of thing.
Yeah.
I mean, everybody's in kind of a group, or a lot of people are in professional groups that I'm in a communicators group that we sit around once a month, and we, from different companies here in Louisville, and we talk about, all right, I had this happen to me, and I'm facing this problem, and you can kind of go back and forth on how would you solve this, or how would you help me do this? Is that kind of what we're talking about here?
It's exactly what we're talking about. And one of the things that it helps address is that we know that mentorship is really key to longitudinal success for academic physicians, but yet mentorship is really variably available at different institutions, and different folks have different needs for mentorship. And so this is just one way to potentially address that. One unique aspect of our model is that all of us were at different stages in our career. And so it wasn't just a group of folks at the same level trying to figure it out, but folks at different levels contributing different things to the group, which makes it a little bit unique.
Again, we're talking to Dr. Michelle Stevenson, the head of the Division of Pediatric Emergency Medicine at UofL. So how does this make Michelle Stevenson a better pediatric doctor in dealing with kids that are in rough shape, a lot of them that you see, I assume, right?
Yeah, so, I think physician burnout nationally is a huge issue, and by no means is our model the panacea for addressing that. But one of the things that's been shown is that connection to others with similar experiences may help ameliorate that. And I think for me personally, having a group of women across the country who are facing challenges similar to my own in terms of navigating all the tasks that we do, going into a shift in the middle of the night to help care for children, getting up the next day and helping my family with their activities, and sharing those experiences and connecting over that and problem solving over that has definitely enriched my personal life and my professional life, and I think made me a better doctor.
Have you learned something clinically, at least, or possibly from someone else or that's been in this group that has said, I don't know, did you go with a program, I'm having this kid that came in with this heart problem in the emergency department. Where do you work, at Norton or at
Yeah,
at
I work at Norton Children's and Norton
Children's
Children's
okay.
Medical Center in the Brownsboro area. And yeah, so we do occasionally share, clinical pearls. My other colleagues are all in hospital medicine, and so they're in pediatrics in general, although I'm the only pediatric emergency medicine of the four of us. But I think it's really those sort of shared experiences of just navigating the various tasks of our personal and professional lives that has really been the most meaningful for me.
Thanks for listening to UofL Today with Mark Hebert. Go Cards!